mother's last rites when I was not quite 5 years old. And we surrounded our loved ones, before and after death, with a lot of love, a lot of laughter, a lot of tears. And it was very much a part of life. And so I was much older when I realized not everyone has that my friends, if they weren't shielded altogether, they said goodbye to loved ones in hospitals with lots of wires and tubes. And there was a lot of fear around that. So I kind of helped my friends, supported my friends and other family members. Even after I left Catholicism, later as an adult converted to Judaism, I brought all those grief rituals with me. And I brought the idea that death was a normal part of life with me. My career spanned 30 years. I was a political organizer, especially around progressive causes in Florida. I also worked as a newspaper columnist for 10 years. I was a high school and college educator for 8 years. And around the pandemic, just decided that the political realm has gotten a little toxic. Don't know if you've heard, but I decided I wanted to continue to advocate for people, but outside of politics. And I had been a long-term volunteer with 2 different hospice organizations in Florida. I loved it. Somebody said, you're actually doing this work. It's death doula work. It's more and more people are wanting to make it less of a medical event. They want to die at home with loved ones rather than in a hospital with strangers. And so I went back to school, went to the University of Vermont, got trained. In addition to all my hospice work, I also joined National End of Life Doula Alliance, and I became a certified through them, credentialed end of life doula. My psychedelic experience was just experience as a young person, not knowing anything about set and setting, but having a wonderful, mystical, life-altering experience. And then again, as a 50-year-old, I rang in my 50th birthday at an ayahuasca clinic or ayahuasca retreat. And so it seemed quite natural to me when I set up my practice to include psychedelics as one of many tools that can help people reduce their fears, their anxieties. What's nice is you don't need a terminal diagnosis to begin this journey, to begin this work, so that you can not only have a wonderful death someday, but a less fearful life right now. So that's my story, and I'm so thankful to be joining you all today.
Thanks, Catherine. Lynda, tell us about yourself.
Thank you so much. Let me unmute. A little bit about me. I provide individuals and groups with therapeutic psyche-spiritual care for journeying, aging, and dying well. I also provide educational presentations and mentoring support for people who are also doing this work. While I am also a trained and experienced healing arts provider, sacred death care doula, home funeral guide, and psychedelic integration therapist, my focus on this panel will be from the perspective of my expertise as a clinical hospice chaplain. So I am a spiritual care provider specialist. This is it's a professional position as part of a multidisciplinary hospice healthcare team, which includes medical doctors, nurse case managers, social workers, complementary therapies like music, pets, massage, and trained volunteers. It also includes the patient's family, private hired caregivers, faith-based clergy, and specialists like doulas, psychotherapists, and psychedelic integration therapists. My own spiritual journey began in 1987, a long time ago, driven by my own health issues. I found that I hadn't been breathing for like 45 years. Surprise. From there, I was guided to where I am today. From my service as a yoga and meditation therapist for several decades and a resident yoga and meditation teacher at a center in Costa Rica, I went to Peru and Ecuador for an intentional ethnogenic quest to discern my life's purpose as a mature woman with very fast approaching elderhood. So that quest clarified my path to serving those experiencing transformation and expanded consciousness through journeying, illness, aging, and dying. In order to best prepare for that, and to get the credibility that I felt that I needed to be safe and effective for this population, I studied for 3 years, graduated, and was ordained from an immersive interfaith seminary with a focus. My focus was on end of life. I completed the Sacred Crossings Death Midwife program with Olivia Bearhan, the Being with Dying program at Upaya Zen Center with Roshi Joan Halifax, and several hospice volunteer training programs, including the Twilight Brigade, which is the Veterans Administration Hospice Volunteer Program. For me, clinical pastoral education is a mandatory requirement for a professional clinical chaplain to be clinically literate, as well as pastoral and personally integrated and clear. I was so grateful. I was chosen as the palliative and inpatient hospice chaplain for my year-long residency at UCLA in Los Angeles, where I was experiencing ICU, geriatrics, oncology, medical surgery, behavioral health, and so much more. When I completed that in 2015, I established my private practice, which I call Wellspring Passages. I trust that each one of us has that internal wellspring of wholeness. And soon after, I began working 4 days a week as a holistic interfaith chaplain, clinical chaplain for the Community Hospice of Columbia and Greene counties of New York State. Identifying that most of my patients with any experience at all of expanded consciousness at any time in their lives had an easier time at end of life, an easier time with diagnosis. I earned a certification as a psychedelic integration therapist to include that as part of my toolkit. And I also completed work as an internal family systems informed practitioner. I'm a member of the National End of Life Doula Association and the National Home Funeral Association. More to come. Thank you. And I know there's a wide range of experience in this group, and I feel very honored to be here. And I love everybody that is showing up here doing this work and educating about more. Thank you so much for showing up.
Thanks, Lynda. And last but not least, Heather.
Hello from Boulder, Colorado. So I am, I've been a therapist for over 30 years. And it's interesting how, it's a long and winding road that sometimes gets you where you land, and you don't always see how all the dots are going to connect. So early in my career as a therapist, I've always been really interested in non-ordinary states of consciousness. So studying dream work, went to Harvard and did training in mind-body medicine. Always really interested in nature immersion, these alternative states, dream work, past life recall. A lot of that sort of non-ordinary and metaphysical is always kind of called to me. And I was always just sort of weaving it into what I was doing in my private practice, but kind of on this, like on the down low, because it wasn't what most clinicians would say was like legit. And then, flash forward and I get the opportunity. I just turned 60 and I get the opportunity a little over a year ago to become one of the first certified psychedelic assisted psychotherapists in the US through the Integrative Psychiatry Institute. So it's like, wow, all my cool hippie stuff is now like legit and I can call it part of my career. When I got that certification through the Integrative Psychiatry Institute, I took it upon myself to fly to Jamaica and live in Jamaica for 3 months, leading back-to-back psilocybin retreats and doing a deep dive working with this medicine, which I was already familiar with in my own personal experience. And a couple of the other sort of, synchronistic things that aren't coincidence. The week that I received my certification as a psychedelic assisted psychotherapist, I also got a breast cancer diagnosis. And I'm like, well, wow, that's kind of crazy. So just a little over a year ago, had a double mastectomy, went through the whole cancer journey. And the first thing I did with that new diagnosis, my personal tale, the first thing I did was a 5-gram journey on mushrooms. And I will tell you about that later because I don't think this is the part I'm supposed to share that. But, so really some personal experience using this medicine with cancer, and I now work with women with cancer and women with end of life using psilocybin to provide that, deep psycho-spiritual support around some of those existential angst. And then the quick piece, my relationship to hospice and palliative care, I went through, I'm not going to give you my resume. I'm going to tell you the down and dirty truth of it. I went through this like really horrible divorce. I had been doing women's wellness retreats all over the globe, flying around the world, working for the Four Seasons, Golden Door, doing all this really cool, fun stuff. Had a divorce and they said, yeah, no, that's not going to work. You need health insurance, you need a job, you need to, and the only job I could get at that point in time was with hospice. And I thought, I don't like dying. I don't like old people. This is not going to be good. I started working for hospice as a medical social worker, and it was the most profound, spiritual, meaningful. I was like, oh my God, you're paying me to do this. This is like the most sacred honor to sit at the bedside with people that are terminally ill. And it brought all that psycho-spiritual, metaphysical, woo-woo stuff. And I'm like, this is powerful. So I'll leave it there for you. But that's my connection to some of these components.
That's great, Heather. Well, you know what, since you're on a roll, you can start this next part, because what we had talked about doing is sharing more of your perspective on how you see psychedelics helping your patients or clients, and sharing a story or two. And I suppose you could tell the story about the 5 grams that your friend did. So,
I'm in Colorado. I did that full up legal, girlfriend.
But yeah, but talking more about your perspective, what you bring, what you think psychedelics can do, especially for this population. I think part of this too is, in the psychedelic bubble we all live in, we talk about preparation and integration, and people don't necessarily know what we mean when we say that. So as you talk about, your perspective, if you could weave that in as well, all of you. But yeah, Heather, starting with you.
Yeah, so I'll just tell my personal tale with cancer and psilocybin and how those came together and were so supportive for me. And it's now a model I use with clients. So, I got this diagnosis and I decided that I needed to really understand kind of what was going on a bigger psycho-spiritual level that led to this dis-ease in my body. So I knew that, modern medicine could handle the whole, I decided just to go for it. My mother had died of breast cancer and she got diagnosed at the same age as me. And she chose to just do a little lumpectomy and a little of this and a little of that. And it came back 15 years later. And I thought, yeah, I'm not going to walk. I'm going to do this journey differently. Go ahead, take everything off, double mastectomy. They were getting a little tired and saggy anyway. Build me some new ones. It's all good. So I did this big deep dive with psilocybin. I have obviously friends and colleagues in this space, so somebody who could support and guide me. And my preparation was really about that. My intention going into this was to really understand, as I said, what is going on other levels that I don't have access to that potentially relates to this dis-ease. I'm not going to say cause this disease. I think we want to be careful about, blaming the victim, right? Like I didn't ask to get cancer, but I wanted to understand what other components might have gone into this. So on my,
if you want it.
so on, could everybody mute, please? Yeah. So on my journey, first I always do intention cards. I do oracle cards, and the cards that I drew talked about facing your fears, dancing with the devil, and trust, which seemed rather appropriate. So I went into this journey, and on the medicine, which was pretty, it was pretty scary at times where I was, because this was early in my diagnosis. So I didn't know how this was going to look for me. And I have 2 beautiful daughters in their 20s. And of course I was facing a lot of existential angst and fear and thinking, oh my God, is this, So, and these are things that our clients and patients and people face. And then we all face. I also work with a lot of college kids who have eco anxiety and distress about the state of the planet. another story. But anyway, so on my journey, I got all this information and download about that I had patterns of fear-based thinking that I'd been carrying for years, that were ancestral, that were from my mother and my grandmother, that were so deeply tied to trusting my partner and being in relationship and not having fears about finance and scarcity. My mother got divorced when I was a very little kid, anyway, whole stuff that came so clear to me on the mushrooms. And the message I kept getting was, you need to release these patterns of fear-based thinking. You need to release fear. You need to live in trust, and you need to live joyfully. You need to find ways to, when you notice those patterns of fear-based thinking, let them go, move into a place of joy. My mother's name was Joy. My mother died of breast cancer. The mushrooms kept saying, you need to live joyfully. This is your opportunity to change the intergenerational fear-based thinking. That was my journey on the mushrooms. I came out of that journey, went through my whole medical experience with this breast cancer thing, kept telling my oncology people and all the doctors all of this stuff. And they're like, we don't really know what you're talking about, but it's very interesting. I said, well, it's coming. So I'm setting the stage for you to hear this piece of the journey. And the other thing was that it came through on the mushrooms. And it's, again, it's how things might come through for when you work with clients. I got this message that I needed to go deep into the wilderness, and I needed to cleanse my body in nature and prepare myself for all the medical hoo-ha stuff that was coming down the pike. So we went off into the wilderness of Escalante, Utah, found this magical place with this river and this waterfall. If anybody's been to Lower Calf Falls, I mean, it's like a frigging sacred, magical thing. We got there, I don't know how. Well, I do know, it was like magic. There was nobody there. This is unheard of. We hiked in, had the waterfall to ourselves. I stripped down butt naked, bathed in that water, which to me was sacred healing water, and prepared my body for all the stuff that was to come. And flash forward to, I am not a tattoo person whatsoever, but I'm now a year out, and I'm going to get tattooed on the side of my new boob the word joyful, as an homage to the medicine. And my 20-year-old daughters are going to like help me pick the font. They said that was very important. So on the flip side, for integration from that, so that was my journey. And that to me is psycho-spiritual, energetic information that is as much a part of my medical experience, well, as anything else. Okay, the doctors knew, but that to me was really meaningful, gave me meaning making, gave me empowerment, gave me what I could be doing on my cancer journey. And that's the piece that I work now with clients on. How do we take the symbols and the messages and the magic and what comes through with the medicine, and how do we make that have meaning for you in your journey? And psilocybin's not going to cure your people's cancer, but it's going to give you a way to walk that path in a way that you feel now empowered and can see things from different perspectives and on different levels, and intergenerational, and the bigger magical spiritual piece of it. And I work with I have a couple clients right now who are very late stage cancer, and they know that that psilocybin is not going to change the course of their disease, but they have such a different piece and perspective. And that's what these medicines offer.
Beautiful, Heather. Thank you. All right, Lynda, I know you come at it from a deeply spiritual and sacred place, so looking forward to hearing your perspective.
Well, thank you very much. And thank you, Heather, especially with that meaning-making part, and I'll address that in a minute. As a little bit of a way of orientation, my clinical chaplain role is a specialization as part of a team. And it's really to support a client's experience of transformation, whether they want it or not. I call it the hero's journey, because it's like somebody knocks on the door, pulls you out, yanks you out, you don't want to go, and you are thrust into the jungle or the forest, and you just have to figure out what resources you have. Generally, everything is stripped away that is not essential, leaving you with what is most important, and that is a gift. For me, with compassion and extensive clinical expertise, a lot of training and supervision, I engage with the person's very own idiosyncratic spirituality of beliefs and values for how they make meaning of what is happening to them. What is their emotional experience of uncertainty, lack of trust, anxiety, fears, anger, and regret? What are their goals for symptom management? and the cultivation of spiritual growth through their connection, discernment, integration, gratitude, and hope. I used evidence. So how do we do that? First of all, I use evidence-based spiritual assessment tools to help identify a person's spiritual strengths and their challenges. Using their own beliefs and trusting the wisdom of their own inner healer, I support them in integrating new information to make meaning of what is happening and also to cultivate that personal growth. And throughout this process, I'm in very close communication with everyone as part of their care team. So I share information, I get information, everything that's kind of, I call it sort of a safety hammock around that person. A couple of clarifications and things that are very helpful. First of all, the term chaplain. People, it's weighted with all kinds of things. That basically, a chaplain is a title, like social worker, doctor, nurse. Chaplains come from many faith traditions, very faith specific and interfaith. Unlike a minister, a priest, a rabbi, imam, who serve a congregation or membership in a place of worship, healthcare chaplains provide spiritual care in hospitals, nursing homes, and private residences for those of all belief systems. For example, St. Peter's Healthcare has 82 drop downs, 82 flavors of belief system, and then there's also other. So it's all over the place. Another word that needs some clarification and deeper understanding in general is the term spirituality. Spirituality is a person, an individual's belief system. It may or may not include religion, which is more of a collective, of a group sharing of belief ideals. And it is an individual's perception, integration, and how they make meaning of a lived experience. So spirituality, straight definition. Spirituality is that aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way they experience their connectedness to the moment, to their self, to others, to nature, and to the significant or the sacred. The most important part of that for me in working with patients is meaning making. And that is the process by which people interpret their situations, the events, in light of their previous knowledge and experience. So this is very important for spiritual well-being, whether somebody is grappling with consequences of journeying or facing some new challenging healthcare diagnosis. So for example, you have a global meaning of how things should be, why bad things happen, chance, fate, destiny, goals, superstitions, and then something happens that jogs that. It might be, whoa, events can happen that are uncontrollable and can damage me. Now, if that agrees with your global meaning, you have no distress. But if it does, then you are in distress. It's spiritual distress. It is important to know that distress is not the situation. It's the gap between that global meaning of how things should be and the meaning that you have in the situation. So few people can do this alone. It requires connection to yourself, large self, I would call it also, that inner healer, that self, reflection, reassessment of how to more deeply understand it, just like Heather did, going in and understanding the patterns. And then to integrate that so you can identify new hope, growth opportunities, and new meaningful goals that you can pursue, new approaches to what's happening to you. Spiritual, emotional, and existential distress and crisis result in an especially severe form of suffering that includes experiences of cognitive dissonance, anxiety, fear, loss of hope, despair. This describes this case study I'm going to share with you, Kevin. So Kevin was a 60-year-old, he did pass. Kevin was a 68-year-old man. His prostate cancer had been in remission for 3 years before it returned with symptoms as a stage 4 with metastasis cancer everywhere. He identified as Roman Catholic because of early childhood education and his family traditions, but he'd only really engaged in the Christmas holiday tradition of tree and gift exchange, and he was not attached to any church or community. His spirituality really was his connection with nature and belief in kindness to others. He and his wife, 2 adult children and 2 grandchildren, were avid campers and nature lovers. He had just retired from a road safety position with the state where they lived, and his wife had retired from years as an elementary school teacher. They'd saved all their lives to retire comfortably and travel back roads and wildernesses across the United States. So feeling very victorious when the cancer was diagnosed as gone 3 years ago, he was outraged with pain when it returned. He hated having to, what he called, continue the fight. He felt, quote, like a failure and a burden to his family. He rated his pain as 10 over 10, but pain medication regimens were not able to touch it. And for me, this is classic spiritual distress. His wife, at wit's end, had urged him to meet with me, which he did. When I met him, he had recently exhausted all medical treatment interventions of palliative chemotherapy, and he was exhausted, angry, and felt like a failure without purpose. He said things like, my doctors have given up on me. I'm going to die, just let me go. But he was also fearful. He would say, I don't want to go to hell for the rest of eternity. His early childhood religious teachings were bubbling up and bringing him visions of hell. These comments and other classical indications of spiritual distress included being withdrawn, irritable, loss of interest in anything that formerly gave him pleasure, no longer playing with his grandkids, not even the simplest hiking in nature, disconnecting from his close friends. His global meaning was that he was a good guy who lived a clean, hardworking, honest life. The situation of his disease and a 6-month end-of-life prognosis were in conflict with that. He deserved to enjoy his retirement years and live a long life. He didn't do nothing to deserve what he thought of as a punishment. He felt like he was being punished, selected, and he was angry about having his life cut short. The overwhelming helplessness and resistance, the uncertainty of when was key. This feeling of being a burden and lack of purpose. If I can't do anything now, why am I just here? I'm just nothing. It was eating at him. He was blinded by despair, and he could not see beyond that without spiritual support. His family was suffering. Instead of coming together during this time, they were falling apart and everyone was in distress. So with non-judgment and compassionate presence, I built a bridge of trust. I was a safe person with whom he could vent his anger at God and the doctors, with whom he could safely and confidentially break down and question, with whom he could tap into for the reflections that he needed on the insight he himself was able to make. I was able to deeply listen to what he was saying and what was not being said, to highlight and reflect back to him his own inner wisdom with beliefs that strengthened him, and to question beliefs that frightened him. We got to a point where we go, who made that rule? And kind of made light of it, but it was questioning things that were dragging him down. We talked about challenge in life that he had faced before and how he coped then, and how experiences seemed to have no upsides in retrospect had gifts of insight and growth. So in this process, Kevin recalled earlier life experience where recreational use of psychedelics, psilocybins particularly, especially when taken in nature under the stars, where he called his happy place of loving connection, were profound and meaningful. Even in these experiences, though, he shared his discomfort at the loss of control, his fear of dissolution, and new ways of seeing his reality that required reassessment and new meaning making. These experiences of expanded consciousness for Kevin were seminal experiences that when he remembered them, it gave him tremendous strength and it gave him pause. So through spiritual care conversations over several weekly visits, recollections of these experiences became the material for further reassessment and integration of his belief in his individual place in nature as nature. his eternal life as energy. He no longer felt alone or punished. He remembered viscerally that deep knowing that he was part of something larger, the stuff of stars. Through this process of connection, reflection, integration, and new meaning making, Kevin's curiosity overcame fear. Gratitude overcame anger. Kevin softened and became interested in what lay before him and how he wanted to approach it. He cultivated patience with uncertainty. He looked forward to car rides and short walks in nature and eventually just sitting outside. He was able to regain his natural warmth, to gratefully receive the personal care that he needed. He deeply reconnected with his wife, his family, and the many friends throughout his final weeks, and he completed a few legacy projects for his grandchildren. He found purpose in showing his family, especially his grandchildren, that he could die well on his own terms with dignity, love of life, and gratitude for being able to be loved by them and to love them until he eventually let go and departed with grace for the mystery of his next adventure.
Thank you, Lynda. That was beautiful. All right, Catherine, as an end-of-life doula, tell us from your perspective what you've done and helped, how you've helped your clients.
Well, so as a death doula, I often think it's important to kind of just mention not only the services doulas provide, but also the services that I don't. So I do like to talk to my clients at length beforehand. I am not a guide. I am not there to fix anything. And I am not there to insert my own personal beliefs, philosophies into the situation. I am there as a supportive presence, both to the person at the center and their care team. And as a death educator, I am in a very similar role. And I think part of trip sitting for my clients is it really does help to come with that perspective. The only things I really come into a room with are curiosity and an open mind. And I think so often we can, experience a psychedelic journey. We can experience the end of life in a way that is more peaceful, graceful, sacred, with that curiosity and an open mind. And so oftentimes when people are at end of life, or if I'm an educator talking to people about end of life, maybe they want a different relationship with death. Maybe they are caring for parents and they want to do it in a different kind of way. But so often we get to discuss fears. Physical suffering, emotional suffering, and spiritual suffering. And as a death doula, I'm happy to say that fears of physical suffering are probably the easiest to tackle. But spiritual and emotional suffering is a little bit trickier. And there are lots of ways that people can right now start to do the very real work that goes into reducing those fears. And obviously psychedelics is a part of it. If I have a client who is not inclined to meditate, who does not have specific religious rituals that bring them comfort, maybe they don't have the time to work with a licensed mental health counselor on traditional talk therapy, then oftentimes psychedelics can be, if they want, a way to reduce some of that, especially those spiritual fears. And so we go through those for them and kind of talk about the pros and the cons. Often my clients work with licensed mental health counselors who are risking their license to provide this plant medicine. And it really does provide them with a lot of comfort. And my work is as a trip sitter involves harm reduction. So I am there to ensure they feel safe and comfortable. They can do a dive and really explore what it is they're meant to understand. And if they need, assistance walking to the bathroom, if they need some water, and then working with the therapist afterward to provide integration so that they can take what they experienced and apply it to the rest of their lives. And so as a result, people end up feeling, I feel like, I once knew a plastic surgeon who refused to show patients pictures of bodies that were transformed because we're all so different. And I don't want anyone on this call to hear a particular anecdote or story, especially of the more miraculous variety, and think that, you know what, that's going to happen for me. So what I like to do is take each person individually, especially when it comes to psychedelics. I can't promise my clients anything except they're not alone. And the same goes for end of life. I can't promise anything except I'm with you on this journey. And sometimes just having somebody walk with you reduces those fears. Sometimes concrete actions reduce fears. And sometimes the integration afterwards can help reduce fears from a psychedelic journey. And so that's oftentimes what we do. But so many have different experiences and different stories. Sometimes it takes one journey. Sometimes it takes several. Sometimes, most of the time, it combines with you. So maybe breath work combined with a psychedelic journey, combined with calling those loved ones and making meaningful amends. Maybe sometimes saying thank you to the people we need to thank, and understanding the beauty of letting go, and saying this was enough. There are so many different ingredients that go into a joyful, sacred, peaceful end-of-life experience. I would hate for anybody to get hung up on just the one. I think it's important to do the work, as my clients say, and to explore all the different mechanisms that are available that often work together to help somebody reduce those fears and have the kind of end-of-life experience that they want.
Thanks, Catherine. That was also beautiful. One of the questions, our listeners might have, I know I've had it, is we generally speak in terms of psilocybin, and all of us kind of have just been talking about psilocybin, but there are other psychedelics. There's LSD, there's ketamine, although not technically a psychedelic, has certainly been used to ease the fear of dying and reduce anxiety and depression. There's others, ayahuasca, MDMA. So I'd be curious to know what you think in terms of what may be best for your clients. Do you recommend, or how do you handle that? And Heather, I'll start with you.
Well, I think, again, I can speak to the medicine that I work with in this capacity with this population is psilocybin. And I also don't go looking for clients. I truly just sit and wait, and people find me who want to work with me, who need to work with me, who feel called to work with me. It all lines up. It just does. So I really can only speak to that. And I'm in Colorado, where it is now legal to have, consume, do, journey on your own personal quantity of psilocybin. So I work with clients here in Colorado with psilocybin. And I also do, I lead women's retreats, and I do retreats in Spain as well, where the laws are much more lenient around some of these medicines. But I really can't speak to, I do work with ketamine, but I'm not with the end-of-life population. So I can only speak to what I do. And I find this to be, my training was with some of the lead researchers at Johns Hopkins, NYU, and really that's where I lean in. I lean into psilocybin for end-of-life anxiety, grief, and distress here in Colorado.
Yeah. Lynda, how about you?
I have some real preferences. One of the things I really like is to start off really guided meditation, cannabis, breath work. I'm a big fan of MDMA for that self-love, and then psilocybin. Those are really and sort of in that order too, depending on what experience people have had before. But I love breath work because you can pull out of it, gives you a thing. I love guided meditation. Cannabis is a gift, all of those things, but particularly the depth work, the teachers from the psilocybin, I think are particularly significant.
Yeah, thank you. Catherine, I know what you will say, but tell everybody else.
So I shouldn't surprise anybody. As a death doula, I am platform agnostic. I am there to support people in whatever they believe is important for them. If they're working with a therapist, then maybe they've decided together what is the best path for them to take. I will also mention something that hasn't been mentioned yet. I work with a lot of marginalized communities. I'm a queer informed death doula. I also am certified, all the groups that I worked with as a political organizer for 30 years are the groups I serve. So that's the LGBTQ plus community, that is BIPOC community, that is deaf and disabled communities. These are communities that as a rule cannot afford to go overseas for retreats. Many of them can't even travel to the next state. So unfortunately, we're kind of stuck in these circumstances that require us to oftentimes explore guided meditation, breath work, cannabis first, because it makes a lot of my clients more comfortable to work with what is safe and legal in their community. And like I said, other times I work with therapists who have taken great risks to provide this medicine for people where it has not been rescheduled or decriminalized yet. So it really is, I am there to support, to walk my clients home, not to make decisions or choices for them. So that I kind of come in with that curiosity and open mind and work with whatever they believe is important or their doctors believe is important to kind of reduce those fears in a way that makes sense for them.
Yeah, thank you. Thank you all. Yeah, from my perspective, when I first started to study psychedelics as it pertains to end of life or cancer or life-threatening illnesses, certainly the body research was around psilocybin. We talked about Johns Hopkins, NYU, UCLA, and now it's exploded. There's a lot of research institutions and private companies looking at this. But I have a friend here in Sarasota who was diagnosed with stage 4 brain cancer. And her depression became so debilitating, she did not leave her apartment. She turned to ketamine. And after the first session, if you know anything about ketamine, you're given 6, we call them loading doses. After the first session, she began to feel her mood lift. After 6 sessions, she began to feel joy and she got a job, which she still holds to this day. You fast forward about another year though, and the disease, her cancer was taking its toll. She suffered from neuropathy and trigeminal neuralgia, pretty much because of the radiation destroyed her jaw. And she turned to ketamine again because it's also very well known to relieve chronic pain, severe chronic pain. And she's been able to manage that pain again to continue her job. So ketamine, there's a body of research there for both palliative and hospice care patients. So I wouldn't rule it out. Catherine touched on a really important point though. It's who can afford this therapy. And this forum is not for that discussion necessarily, but we know that is an ongoing issue and will continue to be. Also wanted to mention I'm also agnostic. My role is to educate. I do have preferences, and yes, I think psilocybin is probably the best for this population. But back in the 50s and 60s, it was Stan Grof and company that looked at LSD in cancer patients and found similar types of results. So, again, we give the information, a person has to make their own decision. So thank you for that.
There's also a little bit of contraindications of certain things too. So even if somebody says, I'd like to do this or that, you might know that if they're on SSRIs or something, that they might not want to be taking psilocybin only because it will be non-effective. So knowing what contraindications might be can help guide somebody to this substance of choice that they might like to work with.
Yeah, that was actually my next question. That's cool. I will tell you what I believe and what has been borne out by real life real life situations is that SSRIs, yes, blunt the effects of psilocybin, any classic psychedelic. However, we first do no harm, and if coming off of an SSRI creates more harm than not, then staying on that SSRI and increasing the dosage of psilocybin when the facilitator knows what they're doing is I think, a response. But anyway, I would like to come back to that because there are contraindications, and especially health, I would put it as health considerations for this population. So Heather, with your experience, how do you view that?
Well, I was going to speak to the accessibility piece real quick because, you know, this audience, we all have the opportunity to make personal choices around that and be part of that, you know, what we feel is good and right about and being part of the change that we wish to see. So, you know, I lead some retreats that are at a pretty high price point for people that can afford them. And that gives me the opportunity then to do pro bono work and give back to clients who can't pay me a penny. So, and I feel good about that. And I think we're all in a place, as if you obviously are all interested in this field, that, you know, you don't have to, you can make the choice to say, I'm going to, you know, see so many clients every year or whatever, and not take any money for that. So we can be part of that change in our own little ways. And your question, Christine, was about
health considerations for this population. How do you come in? How do you view that?
Well, I always do a really careful screening with psilocybin. I want to know people's mental health history. You know, this psilocybin is not right for everyone, as we sort of mentioned. If you've got a history of bipolar, any manic episodes, or even in your first line of family, we're potentially going to do more harm than good. We're going to be really careful about that. And obviously, you know, I do a medical screening. I have people screened that are going to work with me with psilocybin or ketamine so that somebody, an MD, has done given their approval that this person is medically sound for whatever intervention that I'm working with a client with. And that just, you know, that just covers me. It covers them. Psilocybin, one of the reasons that I work with it exclusively as my drug of choice, so to speak, is because it is so incredibly safe. It's safer than anything in your bar or medicine cabinet. It's got less side effects than anything pharma has come up with. I feel so confident in the safety of this ancient healing plant medicine. So, you know, barring a few things that I carefully screen for, I feel really confident in working with this medicine. Again, it's a lot about the preparation. It's about the integration. It's about that connection with the client. I mean, I would say 80%, if not more, of the therapeutic healing component is that relationship, that trust, that safety, that you have that energetic connection with the patient that you're working with.
Yeah, Lynda, did you want to add anything to?
I do. About the accessibility, I know that I offer a sliding scale, and I was really pleased. Somebody recently committed to a session, a package, I guess you would call it, and they doubled it so that I would be comfortably able to support other people who could not afford it. So there are people out there, but I do have it on a sliding scale based on annual income, but also it's open to all kinds of variations, exchanges, all kinds of things. About the health considerations, the screening absolutely is really essential, and I agree with Heather all the way down the line on that. One of the things I would like to talk about too is the importance of assessing what that person is going home to. So I like it when I know ahead of time that somebody has an ongoing therapist relationship or a supportive family or something, because they are going to be somehow recalibrated and rearranged. And so that's important too. And I just wanted to bring that up.
Right. Catherine, you have anything you want to add to that?
Yeah, I'm listening, and I'm also reading people mentioning in the chats lots of talk about how expensive psilocybin is, how expensive ketamine is. And I know that that's a concern for a lot of people. I don't know if that's going to get better or worse. I know that places, even where it's legal or decriminalized, that it is oftentimes cheapest for people to get it underground, to source it themselves, to go and pick mushrooms themselves. And there's a whole host of pros and cons to that approach as well. So I'm very comfortable working with people who have therapists and are utilizing me for, the trip sitting services that I provide. I'm also comfortable with people who have done the research themselves. They are comfortable taking LSD on their own, or maybe psilocybin or MDMA, and they, in the name of harm reduction, want somebody there in the room while they're doing this so that they can feel safe to kind of do that deep dive. And I am comfortable working in those circumstances as well, depending on who the person is, where they are in this journey, where they are in their diagnosis. And then we kind of take it from there, with each individual getting an individual care plan.
Excellent. Thank you. All right. I have a lot of questions myself, but I figured let's open it up to the viewers. One of the things I wanted to say, I know Glenn had posted in there about Ben Malcolm, the spirit pharmacist. And yes, if you sign up for my core course program, Ben Malcolm is teaching the screening and assessment course from the perspective of health considerations for palliative and hospice care patients. So I was really tickled to have him join us on the faculty. I want to come back to Amy's question: how early do end-of-life doulas start involvement with patients? And I know, Lynda, thank you for answering that in terms of ideally, as soon as they are open to discernment and education about options. I would say yes, as soon as they go, oh my gosh, I'm faced with my mortality and it's creating distress, right? And in a similar vein. And I think one of the things I see, one of the things I'd like to accomplish with end-of-life psychedelic care is to educate those individuals on starting an involvement with an end-of-life doula or death doula, or hospice for that matter, way before they typically do, and to talk about that benefit of starting to work with them early on. Just wanted to add that in there. So I'm going to scroll down through the chat real quick, but if anybody has a question, please raise your hand. Okay.
Deirdre's in the wings, waiting on.
Is she okay? Yeah, let me I'm almost to the bottom here. Yeah, okay. Yes, all right. Dee, go ahead.
So I printed it in the chat too, but I was just wondering when Lynda mentioned her evidence-based tool of spiritual assessment, I was curious around that, if she could speak a little bit more like what that looks like. Is it online, or I don't know. It was interesting.
Just had to unmute myself. Thank you. Yes, I'm familiar with at least 7 to 12 different spiritual assessment tools used by healthcare organizations, and they can be from simple to complex. And all of them have been developed in such a way that provides information about where somebody's strengths and weaknesses are and their ability to cope and do well with the interventions that they will naturally be facing. You can go online and just look spiritual assessment tools, and there are a number of them. One that I use that is very simple and uses the acronym HOPE, HOPE, and H would stand for what are your sources of hope, strength, comfort, peace. What are that? You might be so that would be, what are your sources? What can lift you up? O stands for, are you part of an organized or spiritual community of some kind? And describe that. Are you active in it? What's going on with that? Is it supportive? Are you isolated from it? To give some kind of a context for their spirituality, if it is organized, or if maybe it's a sangha. And then P, what are your personal spirituality and practices? And for some people, it's their artwork, could be their relationship with their pets. It could be daily prayer. It could be ritual and altars. It could be dancing in the moonlight. It could be whatever it is. But what is it that they do have that they can call upon during these times? And then E, that stands for what are your beliefs? How did that affect your medical care and your end of life issues? And why that's important, there are certain religious persuasions that do not want blood transfusions or insist on tube feedings, those kind of things. Some also, there are some people that feel like they won't take that pain medication because they haven't suffered enough. They need to suffer more so that they will reach some kind of a higher elevation in their concept of heaven. So how their beliefs influence how they want to receive medical care. And it also then can be, do you want to maintain a certain, can you tolerate a little bit of pain and discomfort if that makes it you're more readily able to connect with your loved ones and those around you? Or there are people that just go, I want no pain, not doing pain. You know, if I'm feeling any pain, put me out, just let me rest, let me sleep, do it. So getting that kind of information helps guide us in how we want to support that person going through it. And it can also change. So as the conditions change, they might come in with a certain idea of what's going to transpire, and then something else comes up and they need to readjust. So we can use this as a guide. So that's the assessment tool. And when it's used consistently by all of the chaplains, it gives a kind of a similar parallel way of being able to see different patients and how they're coping and what their tools are. I hope that's helpful. There's another one called Amen. There is one that the San Francisco hospital uses. It's very complex and really basically saying, if this happens, this means this. If this happens, that means that. I like to go with simple and tap in with my heart and my intuitive abilities and connect with the person with this hope when it works for me. I hope that that's helpful.
Thanks, Lynda. Sarah, you have a question.
I do, yeah. I'm curious how you all navigate cognitive impairment and dementia. It strikes me as potentially playing with fire if a person's whole mind isn't there. So I'm just curious how you think about patients who have cognitive impairment.
They're not a candidate.
Okay.
This is, I know, you know, somebody else might think differently, and then that's their choice and that kind of thing. But the ability to be able to share what the experiences would be for integration would be compromised.
Yeah.
So you might be sending them off and who knows where. And
Yeah.
so that's my opinion.
Yeah, so as a death doula, I work with people who have various levels of cognitive impairment through dementia, Lewy body, Parkinson's, Alzheimer's. But I do not work with them. They're not in a place usually when they contact me where they can make that decision for themselves to try something. And also the fears that people have look differently depending on where they are on that in the progression of those degenerative diseases. So I work with them all the time, but not with psychedelics.
Yeah.
And I think it speaks to what somebody else put in the things about, you know, liability, release forms, and all of the legalities of how you know, have liability. And I'm thinking that that's probably going to be something in Christine's course. Again, I'm here in Colorado where it's legal, but I have spent thousands of dollars with attorneys to make sure that I have like a really good liability form when I'm, you know, working with clients with these medicines.
Well, yeah, since you mentioned that, Matthew, we'll get to you 1 second. But yeah, since that question was asked, I'm curious to know how the rest of you might handle that. So thousands of dollars, Heather, you spent for the
money well spent. Money well spent. I don't look good in orange. I don't want to do this. I want to cover my butt, cover my you know, the people that I work with, I want everybody to be safe and covered. So yeah, money well spent with an attorney.
Lynda or Catherine, do you want to speak to that issue?
I think it's important to have liability insurance. I think it's important to work with attorneys so that you're covered and that your clients feel safe too. And I also work with different retreats and therapists who have those releases and those same kind of liability forms and insurance to protect them at the same time.
Yeah, and for me, through the training with vital psychedelic integration therapist stuff, we had some really good examples of templates for agreements and waivers and those kind of things. And I've crafted those to create something that works for me and also, I believe, keeps the patient safe. We have an understanding of what their responsibility is, what my responsibility is.
Yeah, thank you. All right, Heather, that answered your question. Great. If not, why don't you raise your hand and can talk about it a little bit more. Matthew, your question.
Hey, right here. Yeah, I'm a counselor or a therapist, but I have a background like the Reverend there, like Reverend Lynda. I was as a chaplain, a Buddhist chaplain in my case. So, but I've very rare at a hospice, but I very rarely so far have worked with a dying patient and given them psilocybin just once. And I wouldn't do it again for a number of reasons with psilocybin. I would with ketamine because it's legal, but I wouldn't do it. It's just too much risk. It's a lot of money. And also the people have unrealistic expectations through the media and Michael Pollan and the big treatment and their idea of having the breakthrough vision at a high dose. I found the whole thing as kind of uncomfortable and dangerous legally, but ketamine, I think this is just my personal story, but I'm open to comments or especially about Michael Pollan strip treatment. Yeah.
I'll just say that I think, you know, expectations is a really, really, really important part of the conversation, and really working, that's part of almost preparation, is really making sure that people have appropriate and realistic expectations and not making false promises about what the experience is going to be. It's going to be what it's going to be. And I think you bring up a really good point, because I do think there's a little bit of hype out there that this is, you know, that every journey is going to be rainbows and butterflies, and it's a lot of hard work at times, you know. So I just think that is something that we all in this field are part of, making sure that we're, you know, really representing the messaging appropriately about expectations.
Lynda or Catherine, you want to comment?
Well, we had that conversation the other night when we met. And my opinion is there's something sacred about the end of life and the dying process. And for me, I don't think that it is helpful or appropriate to have some sort of psychedelic at the end of life. When it comes to discernment and preparation, I am all for it. But there's something about it. And then I know Catherine has a different point of view about that, but it just seems like it's, there's something about conscious dying that's very appealing to me. And if you have earlier expanded consciousness and can work with that, I think it's great. I just am concerned about, but I leave it up, and others have other experiences, but I wouldn't recommend it at the end of life when somebody is actively dying or transitioning.
Right. And we did talk about this, and I think my overall view is, again, it's not about what I think is appropriate. It is about what my clients think is appropriate. And especially in this day and age, I have to say, as a woman, as a death doula, I want certain choices and options available to me. And that includes full and complete agency and autonomy. And so because I want those rights for me, I will not take away those rights from anyone else. So depending on the person and their own unique circumstances, what they're trying to achieve, what their values are, what they think is important. I have lots of clients who really do want to die consciously. And then I have other clients who want and have a right to have palliative sedation. And then I have other clients who want something completely different at end of life. And I think each doula kind of has to make their own decision. You know, what I know some doulas who cannot work with children, but who can work with older adults. I know some doulas who cannot work with people who want palliative sedation, but they can with somebody who wants to be dying consciously. I'm a different kind of doula in that I work with people from all different backgrounds, ages, belief systems, and then I tailor my support to fit what they need.
Yeah, I think one of the takeaways from today should be you all need to honor yourself as a healer and as a facilitator, however you think of yourself. Matthew, you feel comfortable with ketamine. You need to honor that, right? Don't let anybody take you out of your lane. That's one of the things that Lynda and I also learned. You know, we each need to understand what our lanes are. Mine happens to be business, so I'm not straying into this territory at all, which is why I love having experts on the call. So for each of you, you need to decide, and how you come at it is going to be really important for your clients or your patients. Anybody here from Oregon who's gone through the psilocybin facilitator training by any chance? If you have, if you could raise your hand. Would love to know. Amy.
Hello.
All right. Yeah, Amy. Okay, so there was a comment in the chat about the Oregon model not having any preparation or integration. Since you've gone through that training, could you speak to that?
Yeah, actually, under OHA regulations, there is definitely required preparation, and we can't require integration afterwards, but it's highly recommended. And so we try to schedule it. And then if people don't follow through, they don't follow through. But yeah, absolutely. Preparation and integration are part of the process.
I think one of the things too is since I'd love to ask you one more question because I think it's important here. I read a lot about the fact that it is a adult supported use model in Oregon. And yes, you cannot, even if you are a licensed psychotherapist, you cannot practice psychotherapy during the session. And I think most of us can understand what that means, but the implication from what I read seems to be, oh, well, then that journeyer doesn't get any psychotherapy, when in fact, there can be psychotherapy wrapped around that care, right?
Absolutely. And that was very clear in our training. Again, I'm not a mental health professional. I'm actually an academic. I teach at Oregon State University, but a lot of the people in my training program, and now I work with IPI, and those are also mental health professionals. The training is very clear about when you are actively working as a psilocybin services worker, you are not acting under your license as a mental health professional, but that doesn't mean that those skills aren't brought into preparation sessions or integration sessions, or, right, as you said, all the other meetings that go into it. It's just actually during the psilocybin sessions, those licenses are not active, and you're acting under a different licensure.
Yeah, thank you for that clarification. Yeah, I'm really excited. My next call today is with a not yet approved licensed service center in Oregon who's interested in end of life. And I see something similar where what I'm interested in is wrapping care around the session, but in this case with an end of life doula. So that doula, and as Amy had pointed out earlier, yeah, we want to bring a doula into a person's life as soon as possible and have that trusted relationship built. Of course, that individual has to go into the session with that licensed facilitator, but then that doula is there to support going forward. I mean, I just love that model, and I want to talk to them about that for Oregon, and also, Matthew, to your point, for ketamine. Do the same thing with ketamine, have a doula participate before, and in this case, during, because it could be in clinic where that person is there, or it could be at home where that person is there. And then going forward for as long as, of course, as that client needs a doula or anyone who does end of life work. All right, let's see. I don't know if there's any other questions in the chat. Let me scroll down real quickly.
Christine, I'd like to bring up something that you mentioned too, and that is really understanding what the scope of your expertise is, and particularly what that role might be, even narrowly, if you've got a broader scope. One of the things for psychedelic integration, I think that's very important if somebody's not a licensed psychotherapist, is that in the integration, they focus on working with the material, the insights that came up during the session. When it comes into more of the psychotherapy context, family, all of those kind of things, that's when you would expand that out and work with their licensed psychotherapist. So I think that's very important to know what your scope of work is, and to be a part of a larger network is what you're describing, of people that have their own scope and lanes that kind of overlap, but with respect, go deeper into your area of expertise.
Right. And it was one of the reasons why I wanted to have a licensed psychotherapist, a chaplain, and a doula on this call, because it is important for all of you to determine with your client the type of care that they want and need. And that is the whole concept behind an expanded care team, that you will make yourself available, or not, you will help your client find the type of resource that they feel and you feel that they need. Alexandra.
Hi, yes. So I know that this was just brought up in the chat. I was actually just responding to that. And I know that this conversation and what's been shared primarily has been focused on the individual in transition and end-of-life care and their experience primarily. However, in my experience with hospice and end-of-life care, I'm particularly interested in also the family dynamic and the community dynamic inside and outside of that individual's experience. And so I know I reached out to a few of you individually, but I wanted to know if anyone was interested or open to expanding the conversation in that direction. I don't know if it's appropriate right here, right now, but I'd love to connect with anyone in that regard on just that nuance on the family dynamic and the community dynamic inside and outside of the person who's actually undergoing psychedelic treatment and in hospice themselves, because I do believe, and I have experienced that ripple effect of the person going through that.
I'll have to tell you, it is so absolutely key. You know, illness is a family affair, dying is a family affair, journeying is a family affair, and it's well known the family dynamics that shift as a result of the different roles being changed, and the upheaval of all of those kind of things. And that in itself is a particular kind of training and expertise to be able to manage family conversations, those kind of things. It's very, very important, Alexandra. Thank you for bringing it up. It's key. Often the person who is standing by, that's the caregiver, is at greater risk of deep suffering than the person who's actually going through it, living their reality in the present moment. And the person around them is completely feeling helpless and doesn't know what to do. So being able to support them is key. Thank you, Alexandra.
No one else has anything to add to that? I mean, Lynda did a good job.
Well, and I think there's that little element right now that while psychedelics are still, you know, there's in many communities and you know, it can be controversial. So if somebody is at end of life and that's something that they really want to try that feels right for them, it's their personal path, that can be this added layer of something to navigate in the family dynamic if, you know, family members aren't on board with that. So that, you know, does create another layer of complexity in working with the whole family dynamic and honoring and supporting the person who's, you know, at end of life and making those choices for themselves.
Yeah, and I just would, of course, I think this probably goes without saying, but I just want to mention it out loud for anybody on the call who might be wondering. I think it's important to think about family support at end of life in the broadest sense possible. And so many of my clients are trans, are part of the LGBTQ community. They do not have traditional family support, but they do have loved ones, partners, caregivers. There are all kinds of different families out there. And so as long as the person has, it could be anybody from longtime partners to volunteers at hospice to neighbors, and including anybody who's appropriate to be a part of this, I think it can be a wonderful addition. And I also think it's important to remember that psychedelics are one tool that can also help people who are dealing with grief, people who are dealing with mourning. It's not just for folks at end of life who can benefit from these tools. The people who are actually, bereavement care is something doulas work with folks all the time about, and psychedelics can definitely help with those folks as well.
Yeah, thank you. I want to quickly address, Katie had asked a question about how people can get involved in this work. I was going to talk about this anyway, so I'll just take a minute right now. So End of Life Psychedelic Care, the nonprofit, offers education classes for training as an end of life doula. So definitely gets at these issues as Catherine's been talking about. And Catherine teaches that class, and I can tell you she can also give you lots of great information as to how you really get involved, the kinds of things that she has done as she just moved from Tampa to Chicago and has begun to build her clientele there. And then, of course, well, Catherine just started that class now. We won't run another doula training class until November. But then come September, we're launching the core course program, starts September 14th. And that is what I was alluding to, where Ben Malcolm will be teaching the screening and assessment course. But it's a 6-course series. And you can go to EOLPC.org for more information on that class. We've got more going on where I want to build this EOLPC connector, and I'm really pleased to say I'm kicking that off. The development is kicking off today and want to have that ready by September. Here's a really good question that Kelly has asked. If any of you have a comment about it, although I know you don't necessarily work for ketamine. Matthew, maybe you have a comment about this. Curious about your thoughts on the option to use ketamine during voluntary stopping and drinking in the conscious dying process. So V said, does anybody have anything to say about that?
Yeah, I'll chime in here. I think, whether you're for or against it, I'm pro-choice, but I'm with Reverend Lynda. I don't like the idea of even medically assisted suicide unless it's something really heavy like Parkinson's or Huntington's disease. But anyway, that is the future. Is people will be combining these things and using ketamine at the very end of life, sometimes combined with medically assisted suicide. And whether we like it or not, I see it, and I see a lot of scandals, and but I don't have experience with it personally.
So I just want to chime in about
Me too.
voluntarily stopping eating and drinking. So I have experience working with people, and I just want to draw a distinction for everybody on the call. Medically assisted suicide is not what we're talking about. That is not legal in any state. It is not in the United States. There is something called medical aid in dying that is legal in several states. That's what I meant. And that is completely different from voluntarily stopping all eating and drinking. So voluntarily stopping all eating and drinking is legal in all 50 states. If you are over the age of 18, you have the legal right to stop nourishment and hydration and die a natural, peaceful death with support that is very comfortable and can be, like I said, a natural dying. So it's not at all connected to medical aid in dying, which is not connected at all to assisted suicide. I don't have experience working with people who use ketamine while they've stopped, all eating and drinking. But like everything, I would be open to the discussion with that person and the provider, and see if it's the right fit for all of us.
And also, I think it speaks to the fact that we're in a place right now where there's a lot of room for research. There's a lot of opportunity for these things to be explored, because these psychedelic medicines are absolutely finding their way into the end of life conversation in a big way. And, I don't know what capacity any of you on this call are in, but that's a great area to do research, to see how that might support people through that, stopping eating and drinking, how that might provide comfort during that process. Very interesting place to explore.
I agree with that. I think that's very interesting. I would like to see that. One of the things that I think is really important is that we make the distinction that it's medical aid in dying. And if somebody wants to stop eating and drinking on their own, it is in no way suicide. We have in the last 50 years been able to have medical interventions that extend the dying process. And we need options, individual choice of what we would like to do and how we would like to have that natural dying process roll out for ourselves. And just as there are medical interventions that extend that life, we need to have some options that say we would like to do it differently.
There was a question too here. I know we're coming up on time, but there was a question here about pain medication specific to psilocybin. Do any of you have comments about whether or not that is contraindicated?
Don't particularly at this moment, but I saw that, one of your speaker, one of the people that's going to be a trainer, Christine, in your program speaks, I think, specifically to those applications, the application of psilocybin and how it relates to many different, treatments that people might be undergoing. So I think that's almost a specialty area for somebody in the field of medicine.
Yeah, thank you. Take my class. It says here, Alexa says, can Catherine say more about the end of life psychedelic training at EOLPC? I would say go ahead and please just look at the website, the EOLPC.org website. And let's see, there was, oh, Lynn, you had your hand up. Did you want to ask a question?
Yeah, I had my hand up for a moment and then I put it down. It was in regards to the VSED conversation. And I think it would be really interesting to have more research around VSED, especially, right during the active dying process. And to bring into account like the indigenous practices of Vision Quest, because when you go into a fast 3-4 days, you often have hallucinations and unity experiences that are really powerful, in that I wonder what the actual chemical would bring to that process. Having sat vigil with people, and part of the reason why I'm in this work is it's a sacred experience. And I personally don't know that I would add the medicine on top of that. But I think it's an interesting question. So I don't really have a question in that, only to share my personal experience and point of view. Thank you.
All right, yes. One more question. One more question. Teresa, I know you put a few things in the chat. I'm sorry. So hopefully you're going to ask that question.
Well, thank you so much. I really appreciate this Zoom meeting. It really has brought a lot of things into perspective and a lot of things to light that I am looking to do in the future. And I'm right now volunteering with hospice. And my question is with the people who have experienced this with hospice patients or end of life, at what point in their journey are they doing the psychedelics? Is it, you know, I had a gentleman that it was a week before he passed. He wanted to have an experience and he did on his own with his son, and he passed the following week. And so I'm just curious, like, at what point during their hospice care or their end of life care are they having their journey? And is there a contraindication to a certain time frame, if that makes sense?
This is Lynda. There will come a time when they're not able to engage or respond. And you would like to encourage them doing any kind of journey work, if that's their choice, at a time when they can come back and share it, make meaning of it. That's just my thoughts.
I think we all know that people get on hospice way too late in the game. I mean, people should be getting on, you can be on hospice, you know, you have to diagnosis of 6 months or less, but I mean, I've had people on hospice for a year or longer. They can just re-up. And I hope that we will all be part of, you know, the sort of paradigm shift to try to make hospice not be so stigmatized. It's not, it doesn't mean you're, you know, people get on it just way too late. So if we can just really encourage people to get on hospice much sooner so that they can benefit from all the psycho-spiritual support that's available to them. And that's half the time, you know, free, like, you know, this is something you've earned. This is your benefit. So.
All right. Well, thank you all. We've come to the end, and it's kind of like sad in a way, because there's just, I just love this topic, and I think as we all do. So I will mention again that the recording will be sent out within 24 hours. I think what I'm going to do, we were going to do this in the chat, but everybody's going to put all the panelists are going to put their information as to how to contact them into the email that will be going out to you. I will also reiterate where you can find information about the courses from EOLPC. I'm also going to recommend that anybody on this call join, if you haven't already, the Palliative Care Psychedelic Therapy Group started by Dr. Michael Fratkin and Jacqueline Smith. It's going to be a really great group, asking for people to join in and share their voice as we move forward in this fashion. It's a shared Google group, but like I say, I will also put that link in the email that you all will get by tomorrow. So I want to thank you all again for participating. I know we all feel that this is important work, and so onward. Thank you. Thank you all.
Thank you, everyone, for your great contribution and work.
Thank you, Glenn.
Thanks for having us, Christine. Appreciate it.
Thank you.
Yeah, thank you.
Thanks
Christine,
very much.
so much.
Thank you.
So nice to see everybody.
I realize I clicked the wrong thing here. So anyway, hey, Greg's still there. Glenn's still here. So it's interesting to see who goes last. All right. Bye, guys.
Thank you. That was brilliant. Thank you.
Bye-bye. Thank you. Bye, Heather.
Bye.